Dina and Dr. Gheda. We move on to our next presentation, Asma. So, Dr. Asma, can you please share your screen?
Okay. ثانية واحدة. Okay, good evening. It gives me a great pleasure to present you today this study that we've done 2 years ago on pediatric aphakia with no capsular support, in which we've compared two techniques, the sutureless scleral fixation to the iris glow lens that is retropupillary fixated. This subject is of great importance in children because they have longer life expectancy. So if they don't have a capsular support, there will be lots of things to take care of. The main options that we have is to do a scleral fixation or iris glow lens technique. So the iris fixated lenses, they include the iris sutured and the iris glow lenses. In pediatric age group, we had only one study on the iris sutured type, and we had lots of studies on the iris glow lenses, even the anterior and the posterior fixated types. But the anterior fixated type has that problem that is well known, which is the endothelial cell loss. So we had the retropupillary fixation technique that was introduced in the year of 1994 to avoid the endothelial related complications. And now moving to the scleral fixation technique, we have the sutured and even the sutureless. The sutured, we know different techniques, the ab interno, ab externo, the Hoffman pocket, and even the Gore-Tex with the Acryos IOL. And now we have the four-flanged technique. So these types of surgeries, they have multiple complications that are related to the sutures that may cause erosion with time and even get exposed, or even you cannot bury it, and even you have the breakage of the sutures. So in the year 2007, we had the sutureless scleral fixation technique that was introduced by Sharios with multiple modifications done by Agarwal. So these techniques, they have multiple, what can we say, modifications to do regarding the tunnel, the tunnel construction, the haptic exteriorization, and even the flap closure. So regarding the tunnel construction, we have the technique with a flap and even no flap, and even with the Y-shaped tunnel. The haptic exteriorization can be done with a forceps, with a suture, and even with a needle, like the Amani technique. And we have the flap closure that can be done either with a glue or no glue. So the aim of our work is to compare these two techniques in children who have no capsular support. And we included 30 eyes of 17 patients in Abu Rish Hospital. But these children ranged from the ages 3 to 14 years old. We even included the cases of severely subluxated lenses, and we excluded the cases with penetrating eye trauma and the uncontrolled glaucoma, severely damaged iris, because at this case, we cannot do an iris glow lens, and in the cases of uveitis and macular lesions. So they were divided into the two groups, and we've done the preoperative assessment regarding the best corrected visual acuity, slit lamp examination, the intraocular pressure. We've done the central corneal thickness and even the specular microscopy. We've done a posterior segment examination with macular OCT in order to identify the thickness of the macula. The IOL calculation was done with optical biometry, and here we have a very important point to stress on, the A constant. In the suture, the scleral fixation, it's a posterior segment, not a posterior segment, it's at the level of a sulcus, or it's behind the iris, and at this condition, we will use an A constant of 118.4. And we know that the anterior chamber IOLs have A constant of 115. But the important point to identify is in the retropupillary iris claw lenses, we will calculate the biometry using an A constant of 116.8 because it's not an anterior chamber and it's not a posterior chamber completely. So it's midway between them. So the surgical technique itself, we will start with the scleral fixation technique. Actually, the most important first tip and trick is that you will construct your flaps to be opposite to each other. The upper flap is is limbus based, and the lower flap is fornix based, so that you have better exposure. And after forming the flaps, you can. Sorry.
I'm sorry. Is the video working? Is the video working?
Okay, it's working here, so I will share it. Okay, so now.
Okay.
Okay, just a moment. Okay, here you can see it?
Yes.
Yes, we can see it now.
Okay. So, so regarding the sutureless scleral fixation, it's very important to construct the flaps directly opposite to each other. So the first flap or the lower flap will be fornix based, while the upper one is limbus based. For better exposure, and after forming the flaps, you will form the tunnel. You can construct it with an MVR, and it's better to do it with an insulin syringe so that you will have a very tight tunnel. Using an infusion, a trocar with an infusion is very important in these cases to keep the globe formed while doing lots of manipulations. So after you make the wound, you will introduce your 23 gauge forceps from the lower sclerotomy, and it's a serrated forceps, and then you will introduce the IOL with the right hand, hold the injector, and the nurse will do the scrolling. The most important tap in here is to hold the haptic from the tap, and it has to be the tap and not any other part of the haptic in order not to break it. So after exteriorizing the lower haptic, the nurse will keep scrolling till the IOL is completely free inside the eye. And the nurse can hold this haptic for you if you're feeling that you're not secure enough. And for the upper haptic, with the handshake technique, you can get the haptic inside the eye and then give it from one forceps to another, and always hold the haptic from the tip, as we can see in here. So here we've got the tip. And in order to get the haptic inside the tunnel, always hold the haptic from the tip and not any other part of the haptic in order not to break it, okay? So this is the lower haptic. Here I'm going to pull it inside the tunnel. So the pulling is better than pushing because you don't know if you're inside a false passage, and you don't want to get the haptic kinked. You want it to be completely tucked inside the tunnel. So it's better to pull it and not to push it inside. And after getting the haptics inside the tunnels, you can watch the proper centralization of the IOL. Here we've got this haptic and the upper haptic, and the IOL is completely centered, and then close your wounds. So this is the scleral fixation, and now moving to the iris claw lenses. You will construct a wound of 5.5 millimeters to introduce the IOL. The IOL has to be flipped so that the curved side is facing posteriorly in order not to have a pupillary block. So rotate the IOL. It will be in the horizontal position, and use the forceps of the IOL to make a very good grip. Don't dilate these cases. So, and now the first haptic is introduced below the iris with enclavation, and then the second haptic will be introduced with enclavation using a Sinskey hook. Enclavate the mid-periphery of the iris, not so central and not so peripheral, in order not to get ovalization of the pupil. So regarding these patients, we've done the post-operative evaluation at the first day, the first week, the first month, 3 months, and 6 months. We did all the examination. We repeated the examination all the times. But at the third month, we've done the UBM and the specular microscopy and the macular OCT at the 6 months. With the UBM, we've done the IOL decentration. We've calculated the decentration and the tilt of the IOL. Basically, these techniques depend on having a line between the two scleral spurs, and then we will identify the position of the IOL according to that line. So the results of these surgeries, or the study, first of all, we are going to talk about the operative time, which was statistically significant. We had a statistically significant difference. The scleral fixation group had shown a significantly longer time. And the intraoperative complications in the scleral fixation group, we had 1 case of broken haptic, 4 cases of slippage of the haptic. If you're doing lots of forces, of pulling forces inside the surgery, you will have a slipped haptic. And 1 case in which we had to enlarge the wound to improve the manipulation of the IOL. The iris claw lens had 1 case of hyphema and 1 case of iris injury while making the PI. So I forgot to talk about this point. It's optional to do a PI or not in the cases of retropupillary iris claw lenses, but we've done PIs in order to prevent any incidence of glaucoma in these children. So the postoperative outcome, the best corrected visual acuity between both groups had shown no difference. The change in best corrected visual acuity also had shown no difference. Regarding the astigmatism, it was higher in the iris claw lens, but in the iris claw lens group, but in the end, they had reached the same level with no difference at the 6 months. And the intraocular pressure, it's also with no significant difference. Regarding the complications post-operative or the intraocular pressure, in the scleral fixation group, we had 1 case of hypotony, and in this case, we've waited. It improved within 2 weeks, and 2 cases of glaucoma, which were managed medically. In the iris claw lens, we had also 1 case of hypotony, which improved spontaneously. And we had 1 case of, and we had also a case of glaucoma that was controlled with scleral trabeculectomy, but actually this was mainly, or we think that it was aphakic glaucoma. It's not related to the IOL itself. So regarding the IOL decentration and tilt, there was no significant difference between both groups. And the corneal affection, regarding the change in the central corneal thickness, there was no difference. And the change in the endothelial count, no difference also. And regarding the change in the foveal thickness, also we had no difference. So the postoperative complications that we've seen in the scleral fixation group is a decentration of the IOL in 4 cases that we had to operate on them. We had a subconjunctival haptic with no erosion. We had a peaked pupil in 3 eyes, mainly due to having a vitreous strand in the wound. We had an IOL capture that was managed only with eye drops. We had an inflammatory membrane that was managed with YAG in 1 case. In the iris claw lens, we had irregular pupil. It's ovalization of the pupil that we can see in here. And to avoid this, just enclavate the mid-periphery of the iris and not so central, and not enclavate the central part or even a peripheral part of the iris. And we had a trauma, but this is really related to the using a vitrectomy probe during the surgery and not to the IOL itself. So we had an IOL haptic piercing the iris. We had also patches of iris atrophy. And we had this enclavation in 3 eyes that we had to go for another time to re-enclavate them. And one of them was after a glaucoma surgery. So we had postoperative inflammation after this enclavation. We had retinal detachment in one eye and hyphema, which is due to creating the PI. So this study is the first study to compare these two techniques, the visual outcome, and the different outcomes we had in here were comparative to other authors. And the operative time was previously mentioned, and it was shorter in the iris global lens group or the iris global lens technique by other authors, but the scleral fixation, we were the first to talk about the operative time in here. The central foveal thickness had shown no changes in contrast to other authors who had reported macular edema. So in conclusion, these two techniques, they are comparable to each other, but the scleral fixation technique needs longer time with a longer learning curve. And so if you want to decide which of them to use, that would be according to the surgical preference, the preference of the surgeon himself, the cost of the IOL, and according to the financial situation of the patient. So we had suggested having this type of an IOL for the scleral fixation technique of longer haptics that may add to this technique. Thanks a lot for your listening.
Thank you, Asma. A very interesting study, a very tough one as well. Dr. Reda and Dina, and also the panelists, if they would like to ask any questions.
I'd like to ask Asma a few questions. First, with all the techniques, the new techniques for a sutureless scleral fixation, do you still find a place for the conventional scleral fixation using sutures?
Yes, I use it. Sometimes, yes, it's still there. You can use the suture techniques. Yes, you can use them. And there is a situation in which you cannot use a sutureless technique. If you have one point fixation at the situation, you won't be able to use a sutureless technique because you will have an IOL decentration. So you have to go with the sutures, yes.
Do you consider scleral thickness in such patients, or in some patients having scleral thinning, in doing tunnels, for example, as a technique for sutureless scleral fixation?
Okay, I did not try that, but if we have this problem, I think we can go for an iris glow lens.
So another thing I would like to ask you, when we choose these techniques for children, especially the tunnels, I mean, children do have a growing globes, growing eyes. Do we consider that or take that into consideration when these globes grow, the decentration or the IOLs becomes more evident by following up these children related to the growth of the globe with age?
Well, actually, I did not see decentration or disenclavation in these patients till now. And while you are constructing the tunnel, it has to be about 2 millimeters from the limbus, not very far away, so that it won't be that the haptics will not be that so stretched. And in these patients, I did not see decentration or slippage of the IOL in which the patients in which the IOL was stable from the start and they did not receive any trauma, it's still stable. But actually, the patients with the iris glow lenses, I've seen more disenclavations because they have lots of movement, and the children, they move all the time.
Okay, then when you see haptic migration, especially subconjunctival, because a lot of cases we see nowadays following up post-surgical intervention. Do you interfere for such haptics, and do you fear from any infection?
No, no. Actually, if you don't have any erosion and you don't have any infection that is evident, just leave it. Just leave it.
Even if you see the haptic subconjunctival?
Yes, yes. Don't interfere with that. This is my experience and the things that I've learned from my professors, but we don't interfere in that. We don't cover it. Yes.
You mentioned that you had one case of retinal detachment in the study. Do you recall the cause of the retinal detachment? Was it a predisposed case from the start? Was it, for example, a Marfan syndrome or having any retinal pathology? Or was it related to a complication that happened to the lens?
Well, it was a case of disinclavation. So after we re-inclavated the IOL, we had a detachment. So most probably it's related to the manipulations that we had in the surgery.
But the child was examined, the retina was examined
yes.
properly before the surgery.
Yes.
And there was no underlying pathology or retinal pathology.
No. But the detachment happened after the second surgery, after the re-inclavation.
Okay. Thank you, Asma. Thank you.
You're welcome.
Asma, I have a few questions for you as well.
Okay.
I need to know, you said there's no statistically significant difference in the tilt or in the IOL decentration between both groups, right?
Yes.
I thought that the retropupillary iris fixation definitely should be more stable and should be more centralized than the scleral.
Yes, it's biologic, but regarding the numbers, having a statistically significant difference, it's related to the statistical tests, the numbers themselves.
No, I mean the mechanism of fixing the retropupillary lens. You cannot measure the IOL tilt or decentration by UBM as you did with the scleral tunnel fixation, right? It's totally different.
It's totally different, but we compared it, yes.
Okay. And I need to know if there is the point where you enclavated your haptics in the retropupillary. You said ovalization happens when you implanted in the middle of the iris diaphragm, right?
No. You have to enclavate the mid-periphery of the iris or the middle of the iris, and not to be that so peripheral and not to be that so central. You will have this stretching or ovalization. It improves with time, but it will be still there. Okay. In the end, it's not a very big problem as long as the patient is seeing and you don't have any glare or a problem, but it's disturbing.
Sometimes the parents get so much disturbed because of the ovalization of the pupil. They think this is an abnormal outcome of the surgery. Actually, I found out that when we fix the haptics at the junction of the outer 1/3 and the inner 2/3, because this is the junction between the immobile part of the iris and the mobile part of the iris diaphragm. The iris is not totally mobile. The medial 2/3 only are mobile. That's why we try to avoid medial part, the central part of the iris.
Okay.
Thank you so much. Thank you for the nice
presentation. Thank you.
May I have one question? You mentioned that also the condition of the iris is very important. And I think you mean by that not just whether this patient, for example, the iris is not regular, or sorry, the pupil is not round, regular, or active. I mean the condition of the iris regarding the iris pattern.
Yes,
right?
If you have iris atrophy, like a case of trauma, and you have this degree of iris atrophy, you cannot enclavate it. You have to find healthy irises to enclavate within the haptic of the IOL.
Because I had one patient where I did the sutureless scleral fixation, and the iris was very flail. He was myope. And what happened in this patient actually is that one time he came for follow-up and it was retropupillary sutureless scleral fixation, and then he came and the optic was anterior to the iris, and then I was like, okay, I'll follow him up because his vision is still good and clear visual access, everything was quiet. And then he came on the second follow-up and the IOL was behind the iris, and then another follow-up, the IOL was anterior to the iris, and it kept going at anterior and posterior, and I realized and that was the fault of the iris was very, very flail. It was really floppy, so sometimes it just moves back behind the lens, sometimes it moves anterior to the lens, and I decided not to interfere at all.
Okay.
I don't anything like this before.
Yes, I've seen one case in which the optic was captured once, and actually the mother had noticed a very funny thing. She told me he was in a dark room, and after that he went out with the IOL captured in the pupil. But actually what we've done is I've given him a Mydriatic eye drops, cycloplegico, and we stayed together in the clinic. And actually, the IOL was not captured anymore. But the only explanation for that by my professor, Dr. Ahmed Mustafa, he told me maybe we implanted the IOL slightly anterior. Yes. So yes. So we had this capture, but it happened once. Luckily, it happened once, and it went back with just giving the patient mydriasis, so it was not captured anymore. And when the pupil closed, it was not captured.
Thank you.
I think the problem in your case, Rasha, was the iris, not the IOL, right?
This patient was he was myope. He had a large globe, and the iris was extremely floppy. And I realized that the iris was, it wasn't the lens that was constantly moving. Yes. It was the iris that was moving anterior and posterior to the optics.
It's maybe because also the high myopes patients, they have this voluminous size of the anterior chamber, so the iris was not like stable.